Welcome, everyone, and we are delighted to have you here with us tonight. Let's make this as interactive as possible. So please start by saying hello in the chat, and let's find out where everybody is joining from. So the webinar tonight will be recorded. We will use the Q&A sessions section for you to be able to ask any questions, and these will be answered after the panel discussion. Any questions that we don't get to, we will also send out after the event with communication so that we can make sure that we get to all of your questions. As I say, it will be recorded and available on YouTube after. So tonight we start with the third and the final episode of the ESC EAS Dyslipidemia Guidelines that we've put together. A little bit of background. If you remember the first episode, we set the scene with Professor Nordesgaard giving us a history lesson on where they all came from, who was involved. We had Professor Wigman also help us understand that the guidelines may differ depending on where you are. National guidelines also have an input into it. It was beautifully moderated by our very own Magdalena de Cor, making sure that we have linked where the guidelines came from, the fact that it's evidence-based, and who is involved. In the second episode, we looked at the 2019 guidelines with help of Dr. Julia Brands, what was implemented. We also then had Dr. Antonio Gallo help us about understanding how practically it is implemented in clinics, what are some of the things that the barriers that they come across. And it was also our lovely Narija Vinu who joined us for the person perspective on how these guidelines can help patients' journey in order to make a shared decision-making with your clinician. Both of these already highlighted the fact that these guidelines are evidence-based, used by clinicians, so patients don't necessarily have to know everything about them, but patient organizations and those who want to understand better about why decisions are made or how they are made, both nationally and internationally, is able to use them and then take them with you if you have questions to ask. Now, for this session, we are going to go into what has changed. We're looking at the 2025 focused update and what that means for us in the future. With this, it's a privilege to invite Professor Janine Reuters van Lenne, who will be joining us and presenting the information. She's INEST Head of Vascular Medicine Clinic at Erasmus MC, a researcher focused on cardiovascular prevention, FH, and specifically sex-specific risk factors, which is definitely an important part for myself. She has played a pivotal role in shaping these guidelines and joins us to share her expert insights and give us an understanding of what are the practical implications and helping to bridge the gap between what is the new evidence and what it would look like in everyday management. I'm also privileged to invite Helga Davidson to join us. She's here tonight, FH Europe Foundation Ambassador and Trustee of Action FCS. She brings us the lived experience, understanding of rare genetic disorders, and offering insight beyond just the clinical data. So she will join us today as the voice of our community with her unique and vital perspective, helping understand patient experience and putting that at the heart of our discussion, recognizing the unmet needs, but also what has been improved on over the years. And then it also gives me great pleasure to invite Professor Florian Kronenberg, Director of the Institute of Genetic Epidemiology, sorry about that, Medical University of Innsbruck, renowned international for his amazing knowledge in Lp(a) world, often describing himself as a self-proclaimed Lp(a) addict. But tonight he's also going to help us by understanding what is the guidelines and the review that they wrote on that. And with that, it is a great pleasure for me to hand over to Janine, if you wouldn't mind starting us off.
So I will guide you through the 2025 ESC EAS Focused Dyslipidemia Guidelines. And then to start off, this focused update was published and announced at the same day during the ESC Congress in Madrid in August. And as you can see here, this was my view when we presented our focused update, and really this was a hall with 5,000 people, and it was totally packed, and even in the back there were people standing, and they were all cardiologists and researchers and people who were interested in lipids. And I thought it was amazing because lipids were not always so popular, but this time everybody wanted to know what was in our focused update. And then first, very briefly, last webinar, you also discussed the 2019 ESC EAS Dyslipidemia Guidelines. And they are still the basis. But since the publication, there have been several randomized controlled trials, but also other developments that could change patient management, and that were ahead of the next scheduled full dyslipidemia guidelines. And that's why 2 years ago already, the ESC and EAS decided to publish this focused update. So this focused update is created especially when the publication of new evidence could influence clinical practice. And it was really, well, we couldn't wait anymore. But there are very stringent rules. So only results that would lead to new or changed, and this is quite technical, class 1 or class 2A, and it means like things you should do or should consider to do. Or on the other hand, class 3 and class 3 are things that you should not do. Those kinds of recommendations were selected for inclusion. So it really had to change your patient management. And then also, all new recommendations are additive to the 2019 ESC EAS Dyslipidemia Guidelines. So it doesn't mean that they don't count anymore. And there are also changed recommendations. We will also come across those, and they substitute those of the 2019 Dyslipidemia Guidelines. And then this guideline was published on the same day that we announced it, simultaneously in European Heart Journal and in our own journal, Atherosclerosis. I will not go over all the topics in the focused update, but some new recommendations that I think are important on risk estimation, also on LDL goals. I think maybe you discussed it briefly, but then it's always good to have it repeated. And something about new LDL lowering therapies, something about LP(a), what changed, and also Florian Cronenberg will comment on that. Something about dietary supplements and vitamins, which is also something that patients, well, have very often questions about. And then also with the upcoming Rare Disease Day, the new recommendations on rare dyslipidemias, such as homozygous FH and FCS. Well, very briefly, and so we have some new recommendations on how cardiovascular risk is estimated in people who did not have cardiovascular disease before. And this is a bit technical, but they have a new risk calculator. It appeared in 2021, but that's later than 2019, so it had to be updated. But also, if there is, for example, atherosclerosis seen on imaging, or people have high calcium on their CT, then it should be considered that those people have a higher risk than you would normally estimate. And there are also some risk modifiers which are not in those risk calculators, and that you can also consider in individuals to, for example, up-titrate, to increase their risk. And also that is important for people to know. So very briefly about these risk calculators, this is what your healthcare professional will use if you not have cardiovascular disease before. And what's very important for those who have hereditary dyslipidemia, such as FH or FCS, you cannot use these risk calculators in these kinds of conditions. So if your healthcare provider, if you have FH, for example, is trying to estimate your 10 years risk on these kinds of charge, then please remind the healthcare provider that you have FH and that you're not like a apparently healthy person from the normal community. Well, those risk calculators, they look at if you're a man or a woman, they look at your estimated 10 years risk of having a cardiovascular event, can be fatal or not fatal, and they are also available for different regions. Well, what's important, and that's new, is that beyond those things that about how your cholesterol is, and if you have hypertension, if you're smoking, there are other risk conditions or demographics that are important for somebody's risk. And that's, for example, if you have a family history of premature cardiovascular disease. We also know that certain ethnicities, such as being from a Southern Asian ethnicity background, they have higher risk. But also if people have a lot of stress, social deprivation, but also and this is important for the women, having women-specific risk factors, such as having premature menopause or hypertensive disorders of pregnancy, including preeclampsia. So for the women, it's very important to also mention these female-specific risk factors. So if you had an early menopause, that means before 45 and especially before 40 years of old age, then you should mention that to your healthcare provider. And then there are also biomarkers if you have chronic inflammation, and also if you have a high Lp(a), then your risk is higher than according to those charts. I think this is something that you might have seen before. So in the new update, they did not change the treatment goals. However, there is a new class, and that's the extreme class, and that is people who had ASCVD, so cardiovascular disease events, which are recurrent despite maximally tolerated statin-based therapy, and those patients who have atherosclerosis in different vessel beds. For example, they had a stroke and myocardial infarction, so in the brain and in the heart. Those people you can consider to have even lower LDL targets, for example, below 1 millimole per liter or 40 milligrams per deciliter. Then briefly about LDL lowering therapy. Still statins, ezetimibe, PCSK9 inhibitors are the basis, but we also have a new drug, bempedoic acid, and especially for people who are unable to take statin therapy, this is a pill, oral drug that you can also use, but you can also use it in combination with statin therapy. Also, there is more room for combining lipid-lowering drugs, especially if a person has acute coronary syndrome, so myocardial infarction, already even in hospital, intensify the lipid-lowering treatment. This is something that is also helps to your healthcare provider to see which combination might be the best combination for you. So there are different kinds of drugs, statins, ezetimibe, but also the combinations of different drugs. And this is the average reduction which you expect. So also based on the baseline LDL cholesterol, then it might be that your healthcare professional will propose not to start with one drug and slowly up-titrate, but maybe to start with a combination of drugs. Then very briefly about Lp(a), because I'm sure that Perry Cronenberg will mention something more about that. And this is, so Lp(a) is not normally distributed in the population. So many people have low Lp(a), and then you have this still, so few people have up to very high levels of Lp(a). And the higher Lp(a) is, the higher the risk. And then together with this guideline committee, we said if it's above 100, then we consider it high. But as you can see here, if you have 300, you have a much higher risk than if you have 100. Well, new is that now Lp(a) measurements should be considered in at least in every adult, and that was not there in the 2019 guidelines. And also that we say that Lp(a) above 105 nanomole per liter actually, then you have to consider this as an extra risk factor. Then something about dietary supplements. I know that a lot of my patients also ask me, like, I don't like to use a pill. Can I use something natural, such as cinnamon, garlic, turmeric, whatever? Yeah, red yeast rice. And this is a study, and that compared patients, randomized them to either rosuvastatin 5 milligrams, that's the lowest dose, or placebo, like a fake pill, or fish oil, cinnamon, garlic, turmeric, plant sterols, red yeast rice. And there you can see that actually only the statin, and it's the lowest dose, lowered LDL cholesterol, and not any of the other products. So this, in combination with like a lot of other evidence, also including that some of these dietary supplements, we don't even know if they're safe. For example, red yeast rice. In Asia, there have been deaths, and now in the European Union, the highest dose is 3 milligrams per day, and that's so few that you can't even lower your LDL. So this is an important new recommendation that we say dietary supplements or vitamin without documented safety, very important, and significant LDL lowering efficacy are not recommended to lower the risk of cardiovascular diseases. And this is a class 3, and a class 3 means do not use this. So in a very to finish off, something about the rare dyslipidemias, homozygous FH and FCS. So in this update, even though it was brief, there were also new recommendations for people with homozygous FH. So again, you have to see this in addition to the 2019 guidelines. So there are a lot of therapies are already mentioned, but the new therapy, which was not available in 2019, is evinacumab. And evinacumab is it's a very difficult word to pronounce, angiopoietin-like 3 inhibitor. And this drug can be considered in patients with homozygous FH already from the age of 5. It says here 5, but in word is here, I think it's 1.5 or something like very young, who are not at goal despite receiving the maximum dose of other lipid-lowering therapies. There's also a new recommendation for people with FCS, because now the first drug is mentioned in the guidelines, volanesorsen, that's the ApoC3 inhibitor that should be considered in patients with FCS to lower triglycerides and reduce the risk of pancreatitis. And actually, this guideline is super new, but this recommendation is already a bit outdated because now we have the newer form of volanesorsen. It's called olezarsen, and that's an improved version of this drug. And it's very recent. It's now approved by the EMA. It's a very expensive drug, so not all countries it's available as yet. And then I was very happy and very honored to be co-chair of this new focused update on behalf of EAS. But we had a whole team, and I would especially also like to thank Francois Marsh and Kostas Kaskinas, who are the co-chairs on behalf of the ESC. So with that, I'm going to, okay, Sharon, you already did it for me.
There we go. Thank you.
And I give the word back to Elsie.
Thank you very much. And it's very good to see that it is still, it goes back to the fact that it is evidence-based, and it was clearly stated with, the different risk factors and the supplements, because I think quite often we don't think of those. So it's good that we can evidence that as well. And there we go. My other speakers have joined me as well. With that kind of in mind, can I now actually ask Florian, you did a review on the guidelines. Would you mind running us through kind of the key topics and findings?
Yeah, I think Janine mentioned already the most important key topics, but Koshray and I decided that we write kind of an overview and explaining some issues in more detail, because guidelines are often very condensed. And you cannot, in a guideline, really explain why this change from score to score 2, for example, what has happened. And we explained much more details on the background for that. And we wanted also to set the stage for the guidelines because it's very important that people are following the guidelines. Therefore, we have to trump and have to explain that the people should follow it and really set the stage. And we would like to convince the people how helpful guidelines can be in the daily clinical practice. I think you want me also to talk a little bit more about the LPLA part. I would expect.
Absolutely.
So. I think this was LPLA got really an update in the update guide, in the focused update, or an upgrade, let's say it that way. It was much more clearer than in the past, yeah, because the 2019 guideline was a little bit confusing. They used the threshold of 180 milligram per deciliter. This is now gone. They explained very nicely the higher the LPLA concentration, the higher is the risk. And this is something often patients or affected people do not really completely understand. They are getting nervous when they have 60 milligram per deciliter. And there's a difference whether someone has 60 or 150 milligram per deciliter. There's a huge difference in terms of risk. And therefore, it was really good that they say very clearly, the higher the concentration, the higher is the risk. And this was important. And another thing was really important when you do not consider the LPLA concentration in the risk estimation, that you really underestimate probably the risk of a given person. And that would be really a tragedy to not consider that, or can be a tragedy. But on the other hand, it's also very important, and they pointed it out also very nicely, that it's so important that you do not only look at one risk factor, not looking at the LPLA concentration alone, but always look in the context of the other cardiovascular risk factors, because they together make the global risk of a given person. And it's sometimes really the case that patients are approaching me and they are getting nervous because they have 60 milligram per deciliter, and then I have to explain them what does that mean. I'm asking them what risk factors they have, and there are some people they have absolutely no risk factors, yeah, no family history about cardiovascular disease. And I say to them always, you can even stand at 150 milligram per deciliter LPLA. Yeah, I can calm them down. On the other hand, when people are approaching me and say, I have a high LPLA concentration, and then they tell me they had a lot of risk factors. They are smoking, hypertension, high cholesterol, and all these things, bad lifestyle. Then I can really explain them, you have a lot of opportunities to fight against your global risk. And therefore, you have already kind of a strategy how you can really manage that. This was in former times. Many people said, why should I measure LPLA when I have no drug to lower it? And this turned out even in the EAS consensus paper, we made very clearly that's not true. You have opportunities to do something. And I explain sometimes to people, when someone has absolutely no risk factors but a high LPLA concentration, then the statistical risk is even lower than the average person in the population, because roughly a third of the population is dying from cardiovascular disease. When you have no other risk factors, your risk is much lower. Yeah? It's a little bit confusing sometimes.
If it's confusing for you, I'm sure it gets more confusing for us. And that's why we're trying to understand it. And I think it brings it really nicely back to the fact that it needs to be holistic and personalized. You know, we looked at the guidelines.
Yeah, maybe I can also give an example. I had a patient, and she had a premature menopause before the age of 40, and she was sent for her cardiovascular risk assessment by the gynecologist. She also had a high Lp(a) and a family history of premature cardiovascular disease. But I think she was at that time 45 or something like that. If you would put her in the normal risk calculator, then she would be like, she's a young woman. She did not smoke. She did not have, she was slim. But so if you would just say to her, well, you show her the chart, you say, well, it's green. Your risk of cardiovascular disease is very low. On the other hand, if you take into account all the other risk modifiers, then her risk is a lot higher.
Yeah.
So also in shared decision making with this person, so her LDL was about, I think, 4 or something like that. And then it really makes a difference what your other risk factors are compared to somebody who does not have all those other risk factors. So in the end, we decided that in her case, and it was really personal, her case, it would be better to start with a statin.
And that was exactly, if we look at the charts that you shared originally, and you did say that that is for normal population if everything else is fine, but we know that quite often there are these comorbidities that then impact on how you should be treated. So it was a nice explanation of actually what we can take back from a patient point of view as well, and understand that these guidelines are there, and we have the risk scores, but to understand that it's not just that individual thing, understanding the whole part of it, but also the lifestyle changes. Quite often we also have to take some responsibility towards that. And that kind of also leads me on to bringing in Helga as well. So for rare disease, in a few days' time, we have Rare Disease Awareness Day, and we have homozygous FH and FCS, which is part of our community. And quite often we've been kind of clumped with a lot of other conditions. So listening to everything that's been said, how do you kind of feel about FCS now explicitly being mentioned in the guidelines?
To see rare diseases mentioned in the guidelines like HoFH and FCS, it's emotionally profound because it represents a long-awaited validation after years of misdiagnosis, dismissal, even self-doubt, and it signals that the condition is real, recognised, and no longer medically invisible. It brings hope to the thought that of not having to constantly explain myself in a clinical setting, and hope that the doctors are going to be now more educated and aware of the condition, while also strengthening a sense of belonging to a defined patient community, rather than being an odd case.
So we know that they are mentioned in the guidelines, and it is just mentioning. It doesn't go into detail as much as some of the other things. But how does what we see in the guidelines actually relate to daily life with triglyceride issues?
Well, the way daily life with FCS actually differs quite a lot from the structured clinical framing that the guidelines give. They focus risk thresholds, lab values, and treatment outcomes, whereas patients live with the continuous practical, physical, and emotional consequences that having a rare disease like FCS. That's not mentioned in the text at all. Our daily risks are constant label checking, meal planning, anxiety around social eating, explaining our dietary restrictions to others, and just knowing that a single dietary mistake could have very bad physical consequences, the worst being a pancreatic attack.
So I will come back to Janine and Florian as well in a minute, but from a mental health perspective, in the guidelines, what would you have liked to have seen? We know the guidelines are evidence-based, and that is sometimes difficult when it comes to mental health and psychological side of things. But what would you have liked to maybe have seen in the guidelines to help?
From the mental health side of things, they don't capture the full quality of the burden of FCS, because alongside the clinical risks and the treatment pathways, we live with constant invisible psychological social impact. So it'd be quite nice if they put a bit more information about that into the guidelines as well, because FCS, like a lot of rare diseases, is multifaceted. It's not just lab results.
Yeah. So if I can come to Florian and Janine, and I'll give you both a chance to answer that. So again, we come back to the fact that, the guidelines are, unfortunately or fortunately, you have to have something that you can work with. And so we stick to the evidence and what they can see. is there a way that you can kind of bridge that gap between to being able to manage those kind of mental health side as well in the guidelines?
Well, maybe if I can start off. Thank you, Helga, with sharing your lived experience, which is, I mean, I also have patients with FCS attending my clinic. So I really recognized what you tell me about all their struggles, their daily life struggles, also regarding work, for example, and family and social events. On one of those FCS awareness days, I tried to adhere to FCS diets for one day, and I mean it was really impossible, especially because I had a conference, so I could not even prepare my own meals. So I really think it's amazing how to live with FCS. That being said, about the guidelines, well, this was my first ESC guideline. So also for me, it was a learning curve to see how everything worked. But also to encounter like the many rules that you had. It was really, it's so incredibly strict. Also, because this was a focused update. So it was already a struggle, like what can we get into these guidelines and whatnot, etc. And also, that being said, I think that during that ESC there was also, it was more a consensus paper about mental issues and cardiovascular disease. So you have different kinds of position papers, authority papers, and not everything has to be in a guideline because, for example, sometimes so a guideline is it's a methodology. But sometimes if you do not have specific evidence of trials and you still think it's important, then you can use different formats. For example, for pediatric FH, we are using consensus papers. You have authorization of all kinds of authority papers, etc. So also, I think that you have to see all those kind of papers to cover different aspects of clinical care. So also there, I think like guidelines are not the only tool that we have.
So with that, am I right in saying that actually you have the guidelines, but a good practice for a clinician would be to use the guidelines, but use consensus papers or reviews in combination with those?
Yes, very much so. Yeah, because not everything can be captured in guidelines, and it's just one of the things that we use in clinical practice, but other aspects are better covered in different kinds of formats. Also, and one thing is that in the ESC, in the other, because this was just a focused update, but in the ESC guidelines, nowadays, they also have patient representatives. So I think that if we have a full lipid guideline, then they will have a patient representative as well.
Sorry?
Yeah, I think when we wrote, for example, the EAS LPLA consensus paper, we were also pushed to narrow it down to a certain amount of words and all this stuff. And then we decided after that we bring up a frequently asked question paper, where very many practical things are included, questions which are always coming out in a daily practice, most of the time from the doctors, but also from the patients or from those who are living with the experience. But I can tell you, Helga, we invited Magdalena Dacour to write a review in atherosclerosis on the situation of from the perspective of patient organizations. And I think that's really important to get also their voice, to bring in the patient voice. And the problem is that often we do not have these studies which are really creating the evidence, but those things can also be a basis to think about what can we do to create evidence. And I think that's really important because when we're not talking about how can we create evidence, then it will not happen.
See, I'm of the opinion that if a person's well-being is taken into consideration, the outcome of treatments that are given tend to have a better outcome than because compliance and taking medications and things, I think, is very reliant on the person themselves. And if the person isn't in the right frame of mind, they might not take the medications.
Yeah.
So having a well-being centred approach to healthcare, putting the patient at the centre, I think would be beneficial for the clinicians and definitely for the patient.
Absolutely. And I do think that that is the direction that we are kind of moving in, is making sure that the patient voice is there. And it's small steps, but we are definitely getting there. And I know that there's a couple of questions coming up. So before we actually get to the questions from everybody, because I keep see them popping up everywhere. We talked about things in the guidelines. Janine, you mentioned about people taking natural remedies for some of this. And we know that there's a lot of misinformation out there. But I'm going to ask, from your perspective, I'll start with Florian. How can patients protect themselves from this misinformation when evidence is still evolving? And as you say, we have to collect the evidence, but we don't want to, we want to make sure that we have the right information.
Yeah, I think this is nowadays really a big issue in terms of social media, where all this misinformation is out, and that's not really easy to figure out what is now really a good information source and what is a bad information source, what is behind this certain information. So I have the impression, and therefore it's really important that we have organizations like FH Europe Foundation. They are making these webinars, for example. I think this is a really good source of information. Instead of going from this source, and this source, I would really focus on sources from patient organizations. Yeah, and there are also other channels which are really where experts are working together with patients with lived experience and explain some issues. And when you look at up in the internet, we have, for example, from FH Europe Foundation, we have so many webinars. So they are not outdated when they are 1 year old. Yeah, you get still a lot of very important information. I think that's really important, and therefore I'm really happy that these organizations are available, because they are really important for those people who have to deal with the diseases.
That's an incredible answer. Thank you very much. We're going to go to the questions from the audience now. I have a few that's already come up. So I think the first one is probably going to go to Florian, because it's Lp(a) related. So it says, little question, is Lp(a) now a causal and independent CV risk factor or not? Does it depend on LDL or not? And, how does that work with risk factors?
Yeah, so this discussion about the causality is a very old one. Yeah, but the genetic has helped us very much to figure that out. The genetics helped in the sense that if we have genetic variants which go hand in hand with lifelong elevated Lp(a) concentration, similar as it is for FH, yeah, then we are exposed lifelong to this high Lp(a) concentration. And those people who carry those variants, when they have also much more often cardiovascular disease, this is a really strong support for causality. Yeah, but in the final end, we have to wait also for the trials, which lower Lp(a) dramatically, whether they are also lowering the cardiovascular events dramatically. If this is the case, this is the last piece of the puzzle. So then when they have full clarity, but I'm already now very, very convinced, 99.5%, that this is a causal risk factor for cardiovascular disease. And Elsie, I forgot the second part of the question.
That's okay. We can try that again. So it was just about the, is it a causal independent risk factor? And then, so yes, so you answered it beautifully. So it's all good.
But when we go, for example, UK Biobank, really big data sets, it turned out, independent whether you go to the people who have low or high LDL, diabetes or no diabetes, men and women, it's always a risk factor for cardiovascular disease. The associations are very, very clear.
So those are definite. That's a very clear evidence. The others, we're nearly there. So we're just waiting for the last bit. Perfect. Janine, can I ask you, so I have a question about risk calculators, and I think you answered it already, but maybe just a bit of clarification. The risk calculators that you have, do they function the same for rare diseases as they do for other diseases?
Because especially those risk calculators for people who have not had a cardiovascular disease yet. So if you have had a cardiovascular event, a myocardial infarction or a stroke, then those are not the risk calculators to use, because then automatically you will have a very high risk. So these are for apparently, and they say apparently, they never know, apparently healthy people. But also it excludes people with like rare diseases, for example, homozygous FH. It's crazy because they really, you really can't use those risk factors, because with a person with homozygous FH has a much higher risk than which is mentioned there in the risk calculators. So it's for the like general population. It's not for people with rare diseases, and also not for like FH is not a rare disease, but also for people with FH, because then if you look at those risk calculators, especially if you're a woman and you do not smoke, then you will never qualify for a statin until you're about 70 or something like that, or maybe even higher. And of course, we know that you have to take your lipid-lowering therapy in combination with your healthy lifestyle from actually a child onwards. So, but this is something that I think patients should know, because sometimes still a healthcare professional, a GP or somebody who doesn't know about FH will say, oh yeah, but cholesterol is your only risk factor. For the rest, you are super healthy. You don't need a statin because of these risk charts. But that's not how those risk charts should be used.
And I think that's an important point, because we are sharing all of this with our community, but we want to make sure that they are able to use it appropriately. And I'd like to bring Helga in for a minute. So Helga, you do a lot of reading and you are always sharing it with the community, which is amazing. But how difficult it is to understand, we've spoken today about guidelines, we've spoken about a review paper that explains part of the guidelines, and then we went, well, actually, besides those, we also have a consensus paper. How difficult is it for patients to understand which one to use? Have you found a different way of doing it?
I think quite a lot of patients would just be bamboozled by it, to be perfectly honest. For me to get information, I read, as you said, a lot of papers. Some of the jargon in there is very difficult to understand, the technical data, what the figures mean. I think the best thing a patient can do is speak with their consultant and a specialist that deals with lipids to get the unbiased basic facts about the condition, and stay away, like we said, from social media.
It's a great form of trying to get communication, and as a patient organization, we really thrive on the fact that we want to connect patients, because quite often what we are going through, somebody else is going through, and they can help you work out what is important and what bits we need to go back to our medical professionals for. But it is important to understand that this is a relationship, and so I'm going to come back to Janine and Florian for a second. We want to bridge that gap where patients can go to clinicians and bring these risk scores and say, actually, you've put me here, but I'm not sure, can you explain it? Because when we say you're at high risk, people listening today will be quite scared and think, oh, crikey, this is massive for me. When actually, when you sit down and you work it out, it might be that you are at high risk, but there's things that you can do about it. How can we bridge that gap between clinicians taking what we are saying as not being panicked, but we genuinely want to have a shared communication about our own healthcare, and to be able to then build on the compliance and everything else that goes with it? Any ideas, Janine?
Yeah, what you mentioned is super important. And I also think that in that way, patient organizations like this can help healthcare providers to guide them, like how should I phrase what I find, because indeed in the guidelines to say very high risk, and I can imagine that if you say to a patient you're very high risk, that's very scary to hear. But this is like guideline language. But I'm sure that many healthcare providers really do not really gather that they are frightening those patients. So maybe a campaign for healthcare professionals how to communicate with patients without scaring them would maybe help, and I would very much like to contribute to that.
I think that would be an incredible, where we can all sit around a table and do some role modeling on how to talk to each other. It'd be brilliant. But Florian, also, it is quite a serious conversation, because quite often, we have to respect that the healthcare professionals, they've spent a lot of time understanding these conditions. But from a patient point of view, if we came to them with evidence to say, actually, I don't think you've quite got what was said, especially after, this webinar, how would you suggest that we approach the healthcare professionals?
Yeah, I think we have really to teach them how to communicate. And I think one of the most important issues is, if you are doing scoring and bringing out whether someone is at a high or a lower risk or whatever, then we should not only communicate the risk, we should also communicate what we can do. Yeah, because when you confront a patient only with a score or something like that, then he is going out and is frightened. Yeah, when you tell him you have a high LPA concentration, but we have the possibility to lower your LDL. Your blood pressure is also too high, but we can lower it. We have tools for that. Yeah, then the patient should not be frightened anymore, but they should get the possibility. And when we talk about smoking, for example, there are meanwhile also possibility to help people to quit smoking. Of course we have to communicate that's important, yeah, to do it, yeah, and but we have to offer help. Testing and doing nothing is not helpful.
I have another question for Florian. So from the group, for someone with very high Lp(a), so above 315 nmol, a large part of their LDL-C is due to the cholesterol from the Lp(a) particles in addition to LDL particles. In this case, does the expected reduction in LDL-C due to moderate or high-intensity statin therapy mentioned in the 2025 update take into account the overall LDL-C, including the cholesterol contributed by Lp(a) particles, or the calculated LDL-C excluded Lp(a) cholesterol? Yeah. Now that was a lot. Did you get all of that?
I know this question is always coming up again and again. Excellent. And we do not really exactly know how much cholesterol is in an Lp(a) particle. There are studies which report from 6% to 56%. So it's a huge range. In the past, we tried to correct for that and assumed that 30% of the Lp(a) particle is of cholesterol. And we need more data on that with really big cohorts, because the studies were from extreme patient settings. Yeah? So we have to learn more about that, and then we can be more exact on that. But if someone has a high Lp(a), a very high Lp(a), and does not react to statins, LDL is not going down. Anyway, you should always measure LDL and Lp(a). That's no question. Yeah? But if the person is not going down with the LDL, either the patient is not adherent to the statin, for example, or this is really caused by the high Lp(a) concentration and the cholesterol content of that. And so therefore, you have to always see this in context. And sometimes it can also be that someone who gets a statin, the Lp(a) concentration is going up a bit. And here the focus update was also very clear. They said, if patients have high LDL concentration, they should not stop taking the statins, because the net benefit from the statin treatment by the lowering of the LDL is much higher compared to the disadvantage you might have when LDL is going up by 10 or 15%. I think that's really important.
I think the question on statins is we can do another trilogy just on statins, I think, in the future to make sure that we understand that.
Yeah.
But one of the questions is also, so obviously we know that genetics play a role, and we know that genetic makeup will also impact on your therapies and what will work and what won't work. Do you foresee that the guidelines differentiating the genetics for FCS, clinical FCS, do you think that would come in the future? Is it?
Yeah, well, for the olezarsen, it's now only registered for patients with genetically confirmed FCS. However, so on the one hand, you can say, well, for high triglycerides, there are also other causes. For example, if the diabetes is not well regulated, that's the most common cause, by the way, or sometimes alcohol, etc. And in those kind of cases, of course, the treatment should be to improve the glucose treatment, etc. There are some patients, and they do not have the genetic confirmation, but they still have like clinically FCS. So therefore, I think it's because we do not know everything. We know a lot, but we should not pretend that we know everything. We do not know like all the causes of FCS. So on the one hand, you want to be sure that you're treating the right patients, especially because it's a very expensive drug. On the other hand, I think that we should, so we have those kinds of scoring between FCS, which is monogenetic, like really the genetic form, and the other form is called MCS. And MCS is multifactorial, so there are different factors. You can have like a bit of genetics, a bit of lifestyle, etc. But also, therefore, I think that if you adhere to like the clinical FCS, for example, also in FH, we have patients with FH, and cannot be genetically confirmed. So in that sense, I think that we should make an exception that if you really are sure the patient has a high, well, you have those scores, FCS score, that they should also get access to those therapies. But that's not the case right now.
And I'm going to come back to you again. So again, we have rare disease coming up, but we also have FCS Awareness Day in the future. So definitely something we could come back to and have a bit more information on. But you also said about the dietary supplements when you were talking about the guidelines, and you made it very clear that evidence shows that the dietary supplements are not as good as statins. But do people feel comfortable with taking these? Would you discourage them or allow them to take it in combination?
Well, it depends on why are you taking those supplements? So some people are taking supplements, vitamin D, for example, in the winter, and I really encourage that. And some people feel better with supplements, but also then really mention them to your healthcare provider. If you want to take supplements to lower your LDL, then I think in that case, the guidelines do not support that use. So I think that if you want to, if you have a reason to lower your LDL, then statins are the first choice. And of course, if you cannot take them for any reason, or you need more medication, not only statins, there are a lot of other options as well. But then dietary supplements, and also that is a kind of social media thing, because if you look on social media, there are all those kinds of influencers advertising for all those kinds of products. It's amazing, like what you see, like smoothies or whatever that are cholesterol lowering. Don't believe them; they're fake.
So if you take a lot of garlic, you are alone at the buffet, and therefore your LDL is going up.
Oh, brilliant. That's a great end to this. So I will, for our final question, I'm going to come back to Helga for a second. So Helga, you've listened to all of these. We've had the trilogy come through now on the guidelines and to help patients understand better. From a patient point of view, what are the kind of things that we can do as an organization, but also as obviously the healthcare professionals who support us, to make it easier for patients to understand what is needed or to be able to take these questions to their healthcare providers?
I think for an organisation like FH Europe Foundation that they're doing really well in giving patients voices and giving us opportunities to speak to healthcare professionals that specialise within our conditions. And I think to just expand on that so that it does feed down into the clinics that see the patients would be a fantastic route to go.
Brilliant. So we have a call to action. We make sure that we teach the healthcare professionals about communication and make sure that we get everybody around the table. We are coming to an end, so I am going to have to start finishing up. There are still a few questions left, and I will ask everybody to help me answer them kind of towards the end, and we will send them out with our communication after the event. I want to thank everybody. It's been great questions and very interactive. I want to thank the panelists as well. It was really nice and open conversations, and it's always appreciated when it's like that. We can move a lot better if we are willing to have that communication, as we said. One of the things I also want to remind you that there will be a survey. Please do answer the survey because it helps us to build for the next kind of round, whether it's new webinars or whether it's sharing information. We also have some awareness days coming up. So we have mentioned a couple of times Rare Disease Day is coming up on the 28th. So please do go and have a look at the social media and make sure you share with everybody in your community. We also have LP(a) Awareness Day. So we will be sharing more information about our campaign. There'll be a call to the community next Thursday. Please feel free to come and join us and find out about the information that we will be sharing and the toolkit. We also have HOFH Awareness Day coming up on the 4th of May. Again, we will share a toolkit before the event and make sure that you can follow us on social media as well. The whole series for this trilogy will be available on our YouTube channel. So from the beginning, where we set the environment, to the 2019 guidelines explained, and the great opportunity this time around to look at the 2025 updates will be there as well as Professor Cronenberg had mentioned. There's loads of different webinars there, so please do go and have a look. There's a wealth of information. So thank you again to everybody who joined us. It was great to have you here, and absolutely please join us again. If you have any questions, let us know. You can also find us on social media and on our website. Much appreciated. Again, thank you to our panelists, Janine, Florian, and Helga. You were incredible with the answers. Thank you very much.